Hello everybody. Today we're going to talk about C-peptide and its clinical uses. So let's start with a case. We have Mrs. Smith, who's a 45-year-old female who presents for a follow-up visit after being recently hospitalized for diabetic ketoacidosis. Prior to her hospitalization, she had no history of diabetes mellitus. Her hemoglobin A1C at discharge was 9.5. Her blood glucose levels since discharge have ranged from 95 to 125. She is currently on long-acting insulin and short-acting insulin with meals. Which of the following is the most appropriate management? The correct answer is C, so let's explore why. To start, we need to explore what is C-peptide. C-peptide is a byproduct of insulin synthesis. In the beta cells of the pancreas, proinsulin is cleaved into insulin and C-peptide in equal amounts. So if your body is making insulin endogenously, it's also making C-peptide. Lucky for us, C-peptide is something easily measured in both the blood and urine. So C-peptide can serve as a surrogate marker for endogenous insulin secretion. But why not just measure insulin? Well, insulin often undergoes post-secretion changes that change its circulating levels, so it's not reliable to measure in the serum. So now that we know that C-peptide tells us about how our body is making insulin, how is this clinically useful to us? Firstly, it can help us classify diabetes as either type 1 or type 2. Studies have shown a plasma C-peptide cutoff of less than or equal to 0.2 millimoles per liter is indicative of type 1 diabetes, and of greater than or equal to 0.3 millimoles per liter in the fasting or random state is indicative of type 2 diabetes. This is because in type 1 diabetes, there is an autoimmune destruction of beta cells in the pancreas. No beta cells equal no insulin. No insulin equals no C-peptide or low levels of it. This explains why for our patient, Ms. Smith, we should be checking C-peptide levels. If C-peptide levels are persistently low despite good glycemic control, then we can say that maybe the patient has type 1 diabetes over type 2. This is an important distinction to make, especially in the new diagnosis of diabetes like Ms. Smith, because it has implications on the management of diabetes. This takes us to the next use of the C-peptide, managing diabetes therapies. C-peptide levels tell us how much insulin the body is secreting on its own and can help us in titrating which medications we can use to manage a patient's diabetes. Does a patient truly need exogenous insulin if they can secrete enough on their own? For Ms. Smith, we can use C-peptide in this case to assess beta cell function to see if we should continue insulin therapy or try to taper and try oral agents instead. The next use of C-peptide is not for diabetes at all. It can help us in diagnosing insulinomas and surreptitious insulin administration. In patients with hypoglycemia, C-peptide can help us decide if there is a pancreatic tumor secreting insulin in which C-peptide levels would be high, or if there is surreptitious insulin use in which C-peptide levels would be low because exogenous insulin does not come with C-peptide. So now let's review. C-peptide is a byproduct of proinsulin being cleaved into insulin. C-peptide can serve as a surrogate marker for the body's endogenous insulin production. C-peptide can be used clinically in 3 different ways. Firstly, to help distinguish between type 1 or type 2 diabetes. Next, to help guide management of diabetes medications. And lastly, to work up hypoglycemia and differentiate between insulinomas and surreptitious insulin usage. And one last pearl before you go off ordering C-peptides on your patients. Hyperglycemia itself can cause elevated C-peptide levels, so C-peptide is best interpreted in a fasting state or after a fixed stimulus.